Second part of our prostate session, also a podcast, is on radioligands, very timely. Same panel, we brought up Gary Smith, a friend and colleague from Vanderbilt. Gary, you want to just introduce yourself briefly?
Yeah, Gary Smith, one of the nuclear medicine physicians at Vanderbilt, and certainly not expert in the clinical trials that you all are. It's a pleasure to be here and meet with you. My interest is in quantitative PET imaging, so yeah.
Yeah, and Gary and I work together and treat a lot of patients, so appreciate you reinforcing our panel here. And I'll just read it for the podcast audience. We're also here with Mike Morris, Tanya Dorf, and Karen Audio, and we're going to talk about radioligands. So this is the lutetium radioligand data. Michael, maybe I'll let you sort of walk through this.
Sure. So for those who are audio only, which I think is most of the audience, we're showing a comparison of VISION and PSMAFore, which, as most would know, looked at two different patient populations. VISION was the latest patient population post-ARPI and post-chemotherapy, whereas PSMAFore was post-ARPI pre-chemotherapy, just following along a general prostate cancer drug development scheme that what works late, you just then move earlier and earlier. And to date, that has been met with pretty much universal success without exception, especially now that we have the results from Piece 3, which we're going to talk about later. But VISION was a straight-up success in terms of its outcomes. This was basically a randomization one-to-one of these patients to either a protocol-defined standard of care alone or protocol standard of care with lutetium. These were all PSMA-positive patients by a gallium-68 PSMA PET-CT. And whether you were looking at feel, function, or survive, this was a successful trial. It hit domains in all three key clinical endpoints for regulatory approval, with RPFS and OS being both primary endpoints, and then the FACT-P, several other quality of life assessments, a pain assessment score being secondary endpoints, and basically the trial was successful at all of those endpoints.
Michael, remind us when you say PSMA PET positive, remind me how that was defined for the trial.
Quite loosely, it was only about a 13% screen failure rate. Basically, there was no dual scanning. It was just basically gallium PSMA PET with exclusion of patients who either had negative nodes, viscera, or bone, or soft tissue component of bone by various size criteria. So it was relatively liberal compared with like the Australian approach, which had really high standards for getting patients on their studies. Now, PSMAFore has now had several different pre-planned analyses, and the primary endpoint is mature. The primary endpoint is RPFS, and that clearly was positive with a hazard ratio at its latest look at, of 0.43. This trial had a built-in designed crossover from the control arm for patients who met the primary endpoint to receive lutetium as part of their post-protocol therapy. So that was done on the basis of the feeling from VISION that if you had a life-prolonging therapy and you were offering a randomized trial, that you should have a shot at that therapy if you were on the control arm. Ultimately, however, and I'm not saying that it's necessarily causal, but you can't ignore the fact that over half the patients did cross over in this study. And if you look at the eligible patients, around 80% of them crossed over from the control arm. But OS has a point value of 0.98 with a confidence interval, and this is a secondary endpoint, so it's not part of the design for statistical validity, but the confidence interval does cross one at 0.75 at the lower bound to 1.28 at the upper bound.
And reinforcing your point, the RPFS hazard ratios in essence identical, right? But very different OS.
Yeah.
Right. Same drug, same PET positivity criteria.
Very similar.
Similar, almost identical.
Yeah.
I want to talk a little bit before we move on about sort of implementation in practice. And Gary, to bring you in, we see a ton of patients, and we've been a referral center. They come from all over. They have these outside PET scans, and we don't know. I'm certain that we're treating patients. You can reinforce that we're treating patients who would not have fit in criteria for the vision study.
That's right.
How do you think it's 10% of the patients we treat? Is it 60%? I don't know.
That would have not fit the
qualified for vision
entry
study
criteria
or
for this.
PSMAFore, but we're treating anyway.
Yeah, so we do clearly treat a different population than these clinical studies in real world data. I think we recently published an abstract showing that our results for PSMA did not match the vision trial. But the reason for that, I think, is our patient population clearly higher comorbidities than in the vision trial. So we do take PSMA PET scans from outside for patients who are referred from outside centers. We currently have 30 patients that we're in treatment right now for PSMA, and I would say about half of those would not have met the clinical
vision criteria.
Yeah.
And how often on an outside read do we change from PSMA PET positive to not? Do you know what I'm asking?
Not very often.
Not very often.
Yeah.
So the outside reads are pretty faithful in terms of.
Yeah, we read the PET scans on all the patients that come in. We review those and review the outside reports for those PET scans and look at those to make sure that we concur with the outside reads.
It's generally.
And generally, we're pretty
in
close.
the same ballpark.
Yeah.
Gary, are you treating patients in the PSMAFore patient population, which just, again, for the audience's benefit, that was a trial of patients who had progressed on one ARPI and were randomized to either lutetium or a second ARPI. At Vanderbilt, are you treating those patients?
We're beginning.
FDA has not adjudicated this yet, so that
We're beginning to see patients earlier and earlier in their
I think
therapy.
almost all the patients I refer are pre-chemo. Am I the only one? Katie? Gary? Maybe I'm the only one. How about Michael, are you doing that in practice, or are the others?
Really very, very infrequently at this point, but I think that is obviously.
Why?
I think that there is concern about the reimbursement issues, treating it off-label as to whether the institution will ultimately recover those costs. And I think anytime you need to prioritize patients due to constraints of resources, rooms, staff, pharmacy, et cetera, that you're going to favor the patient who will have a survival benefit as opposed to the patient who won't.
Even though you think that the lack of survival benefit is strictly a crossover
We don't.
issue. Not to put words in
I'm
your
not
mouth,
saying
but
that.
I just did.
I'm saying that I don't know that those are causally related.
Yeah.
But if I have to choose two patients and I have to make a difficult decision, let's say we only have one chair available, I'm going to give it to the patient that I know has a survival benefit.
Fair enough.
That's not to say that I think PSMAFore isn't outstanding therapy and you haven't shown the quality of life data. It is better in terms to be a patient with prostate cancer to get lutetium rather than a second-line ARPI from a quality of life standpoint. But if I have a limited resource and I can only allocate it to one, I'm going to favor the patient who is going to live longer as a result.
Fair enough. Shilpa?
Ryan, at our institution, we can almost never get pre-chemo reimbursement for lutetium. So even if we want to give it, we cannot.
Gary, have we had problems? Am I the only one doing this? Say that again. Yeah. We're just giving
You'll get a call later.
Yeah, I'm going to get a call
Now
after
that
this
you've
session.
publicized this.
That Brian Reaney has single-handedly brought the black ink into red.
Yeah. It's coming out of my salary. Yeah, ineligible for chemo. I got you.
We have tried that too.
But it hasn't worked.
Yeah.
Okay. Things are different here in Tennessee. All right. This is Michael was alluding to this, these different, I guess, non-RPFS, non-survival, like how a patient feels, maybe best stated. And I think, Mike, we were talking about these slides before. This really, and again, tell me if you think this is true, this reinforces that RPFS advantage, right? We don't just want to see scans changing. It's why the FDA has been somewhat reluctant to approved drugs based on response rate or rPFS historically, although not recently.
Yeah.
Because if it's just a scan change, who cares, right? If the patient's not feeling
Yeah,
better.
stuff we just measure is irrelevant if it doesn't help how patients live. But stuff that helps how you live as a cancer patient, I think, is incredibly important. And I actually think that a lot of our community gives not enough service to how therapy improves the quality of life and the experience of living as a cancer patient. When these data were presented at ESMO last week or 2 weeks ago, and it was clear that in every measure, you lived better as a prostate cancer patient getting Pluvicto as opposed to an ARPI. First guy at the microphone said, yeah, but what about the OS? And it's like, wait a minute, are we just saying that quality of life is important, or do we not actually believe that?
Yeah.
So I think that this shows that, yes, our PFS as a radiographic metric is delayed, tumor control is extended, and that then also means that you have a delay in degradation of quality of life, time to worsening pain intensity, time to worsening pain interference, also delayed SSEs. So it's not just something that we are measuring in the reading room.
Yeah.
It is actually translating into a better life for a cancer patient. I personally think that alone, even if you do not live 1 day longer, is worth getting or having access to as a patient. I get that in certain healthcare systems, the value calculus is really important because lutetium is not cheap. But in our system, at least, how you live is just as important as how long you live.
Mike, that is a very important comment because back in the day, mitoxantrone was approved. It did not improve survival, but it was mainly for palliation of symptoms. So I think looking at this is not very often we see such quality of life data for active therapies.
But the question, I guess, so I've been very gratified. Some patients after one dose of Pluvicto are pain-free and their life is completely improved. So I think it works very well. But how would these numbers have looked with a more active control arm, right? Mm-hmm. Would docetaxel also have improved the quality of life by controlling the cancer symptoms?
Well,
maybe not as well, but we don't know.
At ESMO, you do have a hint of that, right? So the upfront PSMA study was presented. This is for hormone-sensitive
We're going to get there. Yeah.
disease. But I won't blow the wind out of those sails, but to address that point, there wasn't an apparent improvement of quality of life with the addition of lutetium, but that's probably because your quality of life is so eroded by docetaxel that it is essentially the dominant picture of quality of life erosion. And I think that also speaks to the issue of the control arm here, that there, even though everyone will say, and this came up as a passionate debate between me and Nick at the last meeting last year, is a control arm that doesn't involve chemotherapy ethical. But in terms of the real world, what patients want is to avoid chemotherapy. And the reason that they want to avoid chemotherapy is because of decrement in quality of life. And so if their choice is a second-line ARPI, now they have something that's more active than an ARPI without the side effects of chemotherapy. So I think that there is a valuable lesson there for the patient population, even without a control arm, that both degrades quality of life and improves overall survival.
And
Sorry, I have a question.
That is docetaxel, I mean. Not Pluvicto.
We all have these patients that have exceptional responses too, maybe after a couple cycles. How are you reassessing these patients, and are you de-escalating treatment as far as extending the interval beyond the FDA label?
That's a question that Jeremy Calais will need to answer in a few years. He's opened up a study looking at adaptive dosing of Pluvicto. So we will see what that study shows, but we've certainly put our money where our mouth is. You'll see an actinium HK2-directed therapy where we are adaptive dosing. I personally do reassess the patient after every 2 cycles. As a group, we've decided to do that with a PSMA PET. And if they do have a CR and they're feeling much better and there's just nothing else to treat and the dosimetry against the tumor with further dosing will just be negligible, but the administered activity to the rest of the body will just be, the 7.4 gigabecquerels, then yes, we do stop at
So you're doing
MSK.
PSMA PETs after every 2 doses?
Yes.
Okay. And no insurance problems getting
None
those
whatsoever.
scans? Okay.
Yeah. Yes, and in Vision, you got your 6 doses every 6 weeks, no matter what
Regardless.
happens, right? Except, of course, clinical progression. But yeah, we are keeping our powder dry for a rainier day, and it also scientifically makes little sense if you're delivering no radiation therapy because there's no tumor visualized, like how much mileage are you going to get out of that dose?
And then you're retreating if they become PSMA PET positive?
Yeah.
Yeah. Tanya, we talked about this last year. This was, I think
Yeah.
you had a different opinion about scanning, or maybe it was
I
Rena.
use PSMA PET,
Okay.
even though we're not supposed to because they didn't envision. But I think exactly what you explained makes a lot of sense. But I don't always use it in isolation to gauge whether a patient's benefiting. Like, it's clear the case you described, but you have cases where the pain goes away, the patient feels better, and the scan doesn't look better. And PSA is maybe up, maybe it's down, ALK-Phos. You look at it all in context, and we'll continue treating, even with the scan. So we don't fully know how to utilize the scans, but I think it makes sense to be getting them and learning, like building our experience with what does a PSMA PET scan look like after 2 and 4 doses.
Tanya's 100% right. Yeah.
And I think we're learning a lot about the heterogeneity when we get these scans before the 3rd cycle also, right? The case of a CR I don't think is common,
Yeah.
where we're saying, do we need to keep going? But the case of there's a mixed response is very common.
Yeah, I was going to ask Gary. I mean, I think I tend to get it after 3 cycles. I think we decided after last year's meeting.
Yeah.
We decided as a group. But I often don't know what to do with that because the PSA is, it's not as clear as, oh, CR, everybody's great, let's just stop. I mean, I'm not sure I've ever seen that, but Gary, I just wanted to ask you, like, how much, when you're interpreting those mid-cycle scans, the mid-treatment course scans.
Yeah, just want to go back to the quality of life issue very quickly. Historically, nuclear medicine has had several tracers, several treatment options for skeletal bone pain that have been abandoned mostly. We still have radium-223 available, which is primarily palliative for bone pain, but does have some survival benefit as well. PSMA is the latest one in that line, and it's not just for skeletal, it's for non-skeletal disease as well. When you start looking at interim scans, historically we have not done interim scans, but we're beginning to see more. I think we're starting to see post-3rd cycle scans being done. What to do with that? That's a great question. But
Are they harder to read for some reason? Or
they're not harder to
Not
read. I think
necessarily.
what we're looking for is to make sure that these lesions are still PSMA avid, because it makes clinical sense that those would be the ones who would respond to continued therapy. But there is a lot of work being done in dosimetry for patients who are receiving lutetium-177 to do post-treatment imaging within the first day to 3 days post-therapy. And there are a number of different protocols that are being developed. Some of the more rigorous ones are doing multiple scans over 3 or 4 days and looking at the kinetics of the lutetium and trying to do dosimetry for individual lesions. Some of the ones that are a little bit more patient-friendly, if you will, are doing single scans 2 days after therapy and trying to extrapolate from the image data what the dose to these tumors are. And I think that dosimetry is something that we need to be aggressively pursuing. I think it's that's going to dictate whether or not to continue therapy more than the interim PSMA scan, quite frankly.
It sounds like there's a lot of work to do in terms of, it's not just like get a scan, it's positive and treat.
Yeah.
Right, I mean, it's obviously more sophisticated, but we haven't really gone down that path and developed those algorithms.
I
Right?
just
'Cause-
want to pick up one thing
Yeah.
that Gary was talking about, and he's absolutely right. You know, we've long had therapy that improved quality of life in strontium and samarium.
That's right.
But the oncologic community always complained, well, but that doesn't prolong survival. So then we had radium, which prolonged survival and made you feel better. And still, oncologists were like, yeah, that's nice. And now we have PS3 showing that in earlier patients, in combo with ENZA, it will prolong life as well. And this is a drug with nearly no side effects. I mean, the impact on the marrow is like 4% to 6%. So I would really like our community to put their money where their mouth is, because these tools are available, and they have been available for a long time and simply underutilized.
Yeah, and I think that is, radium-223 is still an option for primary skeletal disease. They allow a small burden of nodal
Yeah.
disease with
Yeah.
radium-223, but primarily skeletal metastases.
And we're going to talk about piece 3 at the end. Shilpa?
Hard to discuss with the patient what each SUV means, when they report a progression of disease with all of them are SUV 3 or 4, which may not even be clinically significant. Like, can we as a community come up with the threshold for the SUV where it's clinically meaningful? Because patients start freaking out that everything is lighting up, even though Envision SUV of 10 was the cutoff.
So, Shilpa, I'd like to take a different approach. Everybody, no matter what their SUV in Vision, if they got lutetium, they did better than if they did not. The SUV mean, which is not a routinely reported metric on your average clinical report of 10, was only there as a guide for who might most benefit from, but that's been misinterpreted as if you have an SUV mean of less than 10, seek some other treatment. So if we establish a threshold, I think that people tend to forget that these are continuous data, and that generally speaking, getting lutetium is good for you if you have no other treatment choices. And so I would, unless the community understands what the meaning of the threshold is, it seems to be being misinterpreted as do not treat if the SUV mean is less than 10. And that was never the intent, and that's not the statistical message. It's just really a reference point, and I'm not even sure that it's so clear that it's anything other than prognostic. But it's a reference point above which you are anticipated to have the greatest response, but it doesn't mean you're not a responder if you have an SUV of 7.
So I totally agree, and I was going to elaborate on that issue before. I totally agree what you're saying. It's a spectrum, but I think at the same time, the problem is that the control arm of Vision did not have chemotherapy, if I recall. So you have a typical patient who had docetaxel before, and now is in the Vision population, and it would have, especially for good PS patients who are contemplating survival as well as toxicity, they would have cabazitaxel as another option. And so the question has come up, for those patients with that the scan is called positive, but it's borderline positive, is it really the best option for them? And the other issue is the issue about restaging upon progression, 2 cycles, 3 cycles. I commonly do 2 cycles because I think Vision did every 2 cycles. So if you have a patient with significant PSA rise and radiographic progression over 3 cycles, the more you continue with lutetium, the more cytopenias you'll have long-term that I find very difficult to rescue the patient with Cabazi later. So is this a patient that you typically stop after 2 cycles if you see significant PSA rise and switch to Cabazi? Are you even using the PSMA quartiles, the lutetium quartiles to make that decision process? What is your approach?
There's a lot packed into that. So as I recall, 40% of patients on vision had already had cabazitaxel, so that they did not have a whole other spectrum of options. But certainly if you have a patient who could get cabazitaxel and their SUV mean is on the lower side, and I would take the totality of the other data on their counts and their performance status, the goals that they have for their care, because I do think that lutetium has a very different side effect profile than cabazitaxel does, then that's all reasonable information to integrate with the totality of the patient's picture to make a treatment decision that says, I will not give you Pluvicto, right? And you might integrate into that, clearly, SUV mean or SUV max. But if they don't have another choice, obviously, then it's a moot issue.
But it's often, when you're making decisions for patients, it's not necessarily one or the other. It's A then B or B then A,
Yeah.
right? So which one is best now for this patient? We all make those decisions all the time. Doesn't mean they can't get it later. Now, many don't or can't. But,
Right.
Yeah.
And it depends also, like, what's their visceral disease look like? What are the hepatic metastases, which generally don't have that much PSMA avidity relative to their bony disease, and that's going to drive prognosis. And maybe you want to do cabazitaxel in that circumstance.
Do one more question.
Yeah, one question. I mean, Stephanie and I have that experience. We're seeing way more bone marrow suppression than what's reported. People run in low platelet all the time. To a degree, we're asking ourselves, which should come first? Should we give the, lutetium PSMA earlier? Should we give all the chemo possible and leave it till late, etc.? But there is no doubt we're seeing mostly thrombocytopenia than what's reported. I want to see what your experience is.
I would again move you off that point. The point is not to get any specific therapy in your lifetime. The point is to live as longest and as best as you can. Let's say you gave a therapy that precluded a magical therapy, that precluded all subsequent therapy as a single dose up front.
Curitinib.
But it left you with a platelet count for the rest of your life of 70. Okay? So you could get no further therapy ever. That's considered to be life prolonging. But it had durable disease control. Is that good or bad? That's good, right? So when we say, well, the patient can't get chemotherapy later on, there's nothing special about getting chemotherapy, or vice versa. Well, the patient, because we're going to move, I hope, radium to first-line metastatic CRPC. And then someone's going to say, yeah, but maybe, in 3 years they can't get docetaxel. That's not the point.
Yeah.
The point is how long are these patients living with a given sequence, and how well are they living with a given sequence? Not can we cram every therapy into them, because that has its intrinsic value. It's really the survival calculus.
You give whatever you think is the best therapy at the time, and you put the others to the side, and you pull them out later if needed, right? All right, we're on slide 2. We're making great progress.